Bismillah ar-Rahman ar-Rahim. Today our topic is about the pharyngeal separation. My name is Dr. Mohamed Amer. I'm assistant professor in the Department of Otorhinolaryngology, Tanta University. We start with what's called the Ludwig's angina. So the definition of the Ludwig's angina, it's the inflammation and the infection of the submental space, as we can see here. And the etiology, it's in the most of the cases, it's taking place secondary to the dental infection, especially for the teeth of the lower jaw. And for the clinical picture, the patient is suffering from cystic swelling just behind the chin, as we can see in that photo, with difficulty to swallow, causing dysphagia, and other constitutional manifestation, including the fever, the anorexia, the headache, and the malaise. And for talking about the complication, this kind of infection may spread to the nearby neck spaces like the parapharyngeal space, causing parapharyngeal space infection. And as a management for all the deep neck infection, you have to incise the abscess, and here the incision is with horizontal incision just parallel to the chin, as we can see here, to drain completely the abscess till you reach with your hemostat that you are using and the drainage the floor of the mouth. And after the incision and proper incision, you can add the antibiotics, and here the antibiotics should be covering the gram-positive organism as well as the anaerobes. Another type of the deep neck infection, it's called the peritonsillar abscess, or in another word you can call it the quinsy. The quinsy, it's a collection of pus in the peritonsillar space. It's a potential space. Actually, it is closed. It is lying between the tonsil included in its capsule and the superior constrictor muscle. And for the etiology, it is complicating the acute tonsillitis, which arise de novo without previous history of sore throat, or on top of the chronic tonsillitis. For the pathogenesis, it's one of the tonsillar crypts that is usually the crypta magna, which is the largest crypt in the medial surface of the tonsil. It gets infected and sealed off, leading to the formation of intratonsillar abscess, which later on bursts through the tonsillar capsule, leading to the peritonsillitis, followed by the accumulation of pus in that potential space, forming the peritonsillar abscess. And for the causative organism, the most incriminated organism are the Streptococcus pyogenes, the Staph aureus, the anaerobic organism, and most oftenly the growth is mixed. Clinical picture usually ranging from the general symptoms and the local symptoms. General symptoms, it's most commonly due to the septicemia with fever up to 40 degrees centigrade, chills and rigors, malaise, body aches. And for the local symptoms, there are severe throat pain, difficulty in the swallowing causing dysphagia, muffled thick speech, which is called the hot potato voice, the full breath, the ear pain, and the trismus. And here the ear pain is referred along the Arnold branch of the vagus and the glossopharyngeal nerve. And here's a photo representing a peritonsillar abscess of the left side, and here's the accumulation of the pus in between the tonsil included in its capsule and the superior constrictor muscle, and causing one of the cardinal signs for the diagnosis of the peritonsillar abscess, which is pushing the uvula to the unaffected side. And here the uvula is pushed, as we can see, to the right side. During examination for the patient suffering from the quinsy, usually the tonsils and their pillars and the soft palate on the involved side are congested and usually edematous. The tonsil is pushed medially and downward due to the downward displacement caused by the pus accumulated in the peritonsillar space. The uvula is edematous and pushed to the opposite side, and as we said before, it's one of the cardinal signs for the diagnosis of the quinsy. Bulging of the anterior pillar and the soft palate above the tonsil, the mucopus covering the tonsil, and there is cervical lymphadenopathy and torticollis, which means difficulty on moving the head and the neck from one side to the other due to the affection of the sternomastoid muscle. Treatment usually starts with the hospitalization for the affected patients, intravenous fluids and intravenous antibiotics. And here we should take care for the kind of antibiotics that you are using. It should be one of the broad spectrum antibiotics, usually covering the most commonly incriminated organism, the gram-positive organism and the anaerobes. And here the penicillins and their derivatives are the drugs of choice. The analgesics to combat the other constitutional manifestation proper oral hygiene, and lastly it's the incision and drainage for the quinsy. The complication that might take place following the quinsy may be spread of infection causing parapharyngeal abscess or the laryngeal edema, other toxic manifestation including the septicemia, endocarditis, nephritis, and brain abscess, pneumonitis, the lung abscess, jugular vein thrombosis, and spontaneous hemorrhage from the carotid that might be complicated with a carotid blowout. On discussing the retropharyngeal abscess, we start with the acute retropharyngeal abscess, and here we should know by heart that it is exclusively to take place in children, and the retropharyngeal abscess is not known to take place in the adult in acute form, usually in children below the age of 3 years. And here it's due to the separation of the retropharyngeal lymph node, which is called the lymph node of Rovenier or lymph node of Henle, secondary to the infection of the adenoid or the nasopharynx, or of the paranasal sinuses, or of the nasal cavity. In adults, if the retropharyngeal space is affected with acute infection, it's most commonly due to the spread of infection from a penetrating injury or due to spread of infection from the nearby parapharyngeal space. For the symptoms, the patient is usually a child suffering from dysphagia, difficulty in breathing, stridor, crowy cough, and torticollis. On examination, there is evident bulge in the posterior pharyngeal wall, usually is seen on one side of the midline. On doing a plain X-ray, which is the diagnostic modality of choice, there is widening of the prevertebral shadow and sometimes presence of gases in the prevertebral space. And for the treatment, as follow the general rules, there is hospitalization and incision and drainage and systemic antibiotics, and you have to make the airway safe for the child by doing tracheostomy whenever it's needed. On the other hand, the chronic retropharyngeal abscess is actually a tuberculous infection affecting the cervical spine. The tubercle infection of the retropharyngeal lymph node secondary to the pulmonary tuberculosis of the deep cervical lymph nodes. It's caries of the cervical spine presenting centrally behind the prevertebral fascia. The tuberculosis of the retropharyngeal lymph node is limited to one side of the midline. Clinical features of the chronic retropharyngeal abscess are discomfort in the throat, dysphagia, posterior pharyngeal wall swallowing. Usually it's fluctuant swallowing, and most probably the patient is suffering from all the manifestation of the pulmonary tuberculosis. And the treatment in such cases, it's only the treatment of the tuberculosis with senatorial treatment, sun, air, proper nutrition, and all the anti-tuberculous medications. And finally, it's the parapharyngeal abscess. The etiology here, it's a spread of infection from the pharynx, as in cases of acute or chronic infection. The adenoids, the tonsil, bursting or peritonsillar abscess might be extension of infection from the teeth following the dental caries or dental abscess. The ear may be the source of infection, forming the basal abscess or petrocytes. The infection may be spreading from the parotid or from the retropharyngeal space, as we mentioned earlier, or the submaxillary space, and in some cases it's due to penetrating neck injury. For the clinical picture, there is a triad that gather all the cardinal symptom and sign for the parapharyngeal abscess, called the PICS triad. You have to know that PICS triad by heart. It's formed of external swelling, internal swelling, trismus, and torticollis. Starting with the external swelling, which is overlying the angle of the mandible, and then it's the internal swelling. When the patient opens his mouth with difficulty, you can detect the swelling on the lateral wall, pushing the tonsil downward and medially. And lastly, it is the trismus and torticollis. Torticollis meaning the patient is not able to move his neck from one side to the other, and this is due to the spasm of the sternocleidomastoid muscle, and also it's the trismus due to the spasm of the muscle of mastication. Most probably it's the medial pterygoid and the masseter muscle, so the patient is unable to open his mouth properly. Also, we can detect maybe the paralysis of the lower four cranial nerves, swelling at the parotid region, fever, sore throat, rhinophagia, and the other signs of toxemia. And here treatment as well goes with the general rules of the treatment of the deep neck infection. It's the hospitalization, general rules for increasing the general condition of the patient, and the incision and drainage of the abscess. And here the incision is external drainage through horizontal incision just parallel to the angle of the mandible, and systemic antibiotics and analgesics. Complication of the parapharyngeal abscess may be acute laryngeal edema, thrombophlebitis of the jugular vein, retropharyngeal abscess with the spread of infection from the parapharyngeal space to the retropharyngeal space, mediastinitis, which is a fatal condition, and lastly erosion of the wall of the carotid artery, which might be ended with the fatal carotid blowout. Finally, thank you, and I hope you like this lecture.